from the audience, but if there is any point to be asked from the moderator or the chairperson, they can ask. And second request is that you please switch off your mobile phones. Other request is that after first presenter, the next presenter should be ready, and he or she can come over either on the front chair or on the side chair. So this is what I thought that I will give you the instruction, and be brief, be precise, and best of luck to all.
So I would like to request Dr. Natasha Pahuja to start presentation of her first paper. It's novel altered critical intracellular signaling events in keratoconus and its therapeutic potential.
Thank you very much. Good morning, everyone. So what we are essentially doing today is looking at keratoconus with a slightly different perspective. So what is the first thing that comes to our mind when we look at this video clipping? It shows that the gene or the housekeeping is not in order. This is exactly what happens in the term called autophagy. It is the housekeeping gene of the body, or the cleaning mechanism of the body. How this essentially happens is that there is an autophagosome, that means a membrane that forms around the misfolded proteins, and this is taken up in a lysosome and it's degraded. So having understood this concept, we wanted to see if a molecular research can be presented in this format. So what we did was, having understood the concept of autophagy, this fortunately has also won the Nobel Prize in 2016 for physiology and medicine, the concept of autophagy. We wanted to see if autophagy has got any role in keratoconus, because it is related to degenerative diseases in systemic conditions. So what we found, we know that there are certain known factors in keratoconus, be it genetic or environmental. Now what is really essential here is that in environmental factors, oxidative stress is one of the important key factors. What is important here is that the response or the potential cellular mechanism that initiates autophagy is oxidative stress. So having understood this link, we wanted to see if it really happens or not. So we wanted to simulate this in cell culture lines. So what we essentially did was asked if oxidative stress or autophagy can be a factor in pathogenesis of keratoconus. So simulating this in cell culture lines, we induced autophagy. How did we do it? Basically, these are immortalized cell lines where we induce hyperoxia. So hyperoxia induces autophagy. Now we have to see if this can be proved as a concept. What we essentially did, all these cell lines which were exposed to hyperoxia, these cell lines underwent a panel of analysis. Now we did quantitative PCR for gene expression, Western blot analysis for protein, and most importantly, we also looked at inflammatory markers by flow cytometry. Now this is at a molecular level. We also looked at morphological changes in the form of fluorescein imaging. Now what this essentially tells us at cellular level is that if there is increased oxidative stress, there is increased reactive oxygen species which alters the mechanism of autophagy as seen by these specific markers. Now what Western blot also narrated the same story as did the gene expression. Now this was validated by different methods. We quantified it morphologically in the form of autophagosomes, as we can see here, these green bodies, which again show that oxidative stress induces autophagosomes, induces autophagy. So what are we essentially trying to say is that there is defective autophagy, defective cleaning mechanism if there is oxidative stress. We wanted to see if this holds true in patients, in keratoconic eyes. So in patient model, we collected the epithelium, but we had to first ensure that whatever happens in cell lines happens in patients as well. So we collected the epithelium of keratoconic patients from the center and from the non-ectatic or the apparently non-ectatic area, and we analyzed these samples in the same manner as we did for the cell lines. So what are we essentially trying to see is that does oxidative stress as we see in cell lines happen in keratoconus as well. So I have 2 more minutes.
Yes.
Okay, came up. Thanks. So the Western blot analysis in keratoconic eyes also shows that the LAMP1 and the LC3 are deregulated. But what is really important here is that if you look at the expression in the cone, in the ectatic area, which says that there's defective autophagy in the ectatic area, that means in the area of the cone, whereas the non-ectatic area of the same eye of the same patient had normal markers of autophagy, which shows that the disease is localized and autophagy is absolutely localized in terms of gene expression and Western blot. So now we have understood that there is gene expression, or the Western blot says that there is defective autophagy in the cone specifically as compared to the periphery. This defective autophagy can be a potential marker or a potential pathway that alters the pathogenesis of keratoconus. Now we wanted to see if this can be taken up further. So in the entire pathway of autophagy, there are specific markers that can be targeted. Now fortunately for us, chloroquine is something which is clinically available. So we tried this on cell lines. And we tried to induce autophagy or start the cleaning mechanism by treating these cell lines with chloroquine. Now if we look at these oxidative stress cells, which shows that there is increased autophagosomes, but if we treat the same cells, there is optimal autophagy. That means the proportion of autophagosomes decreases significantly. Now this is only in cell lines. What we try to deliberate here is that we know there are certain risk factors. What happens is these cause increased reactive oxygen species on the ocular surface. This causes oxidative stress. Now if the cleaning mechanism is altered, what is going to remove these altered misfolded proteins? This causes altered autophagy. This can increase in inflammation, which has been established in keratoconus now. Now this increase in metalloproteinases causes collagen degradation, which can be a possible mechanism of corneal ectasia. So what are we trying to do? Instead of directly looking at cross-linking, can we find out some potential drug targets that can be treated beforehand? So essentially what are we trying to say is that autophagy is an important role. Oxidative stress has been established. We are introducing a new cellular mechanism. But what we have seen in the body, we are seeing for the first time in the eye in keratoconus. And this altered signaling pathway can probably be used as a marker to establish or test in the future.
Your time is over.
Thank you.
Questions? Any questions from the audience?
Just one question from my side. Whether you told about the autophagy in the keratoconus, whether this can be extrapolated to the peripheral ectasias, like the PMDs and all?
Okay, it's a very, very good question, sir. So, which is not a part of the main text or the abstract, which is why it has not been mentioned here. But if we look at the difference in grade 4 keratoconus and grade 3 keratoconus, the difference in cone and periphery is not significant. So it is only in grade 1 and grade 2. This is probably because the ectasia is extending beyond, which is why we are not able to see that difference. So what you say is absolutely valid.
So now I would invite the next presenter, Dr. Aditya Pradhan.
Certificate to office se collect karenge na? You will have to collect your certificates from the AIOC scientific committee office. You know that. पहले से लोड करा दीजिएगा, टाइम शॉर्ट है.
लोडेड है लैपटॉप चेंज. Good morning everybody. Today I will be taking a glimpse into evolving indications and trends in keratoplasty in Eastern India. This will be a 5-year review. I have no financial interest to disclose. So as we know that penetrating keratoplasty has been the gold standard for over almost 5 decades now for treating corneal blindness. However, the introduction of component keratoplasty has changed this perception, and now we have different surgical techniques and indications for the same. So the purpose of this study was to report the leading indications and shift in types of keratoplasty which was performed at a tertiary center in Eastern India for the 5-year period from 2011 to 2015. This was a retrospective review of data from our iBank and hospital EMR records from January 2011 to December 2015. We saw the leading indications at our center and types of keratoplasty which we did for the same, and we analyzed it and performed it with compared it with published literature. So if we see the total number of keratoplasties which has been on a steady increase from 2011 around 900, and it reached around 1300 keratoplasties at the end of this study period. Now just coming to the leading surgical procedures, that is penetrating, then endothelial, DALC, therapeutic and K-Pro, there is an increase in all these numbers, but most striking at the end of the study period, there are almost 600 keratoplasties done for therapeutic indications, that is active infectious keratitis, and the number of penetrating and endothelial has become almost the same, around 300. If you go into the leading indications, 4 indications most common, that is infectious keratitis in the active stage. One is corneal scarring, bullous keratopathy, either aphakic or pseudophakic, and failed graft. Again, at the end of the study period, the maximum, the most common indication is again active infectious keratitis. However, corneal scar and other indications are also important, but failed graft is becoming an important indication. If you just look into 2 indications in detail, first being bullous keratopathy, the number of PK is gradually declining. Almost only 5 cases we did for the same indication. But if you see endothelial keratoplasty in the form of DSEC or the automated version, almost 250 procedures being done for the same indication. If you see failed graft, the number of PK and EK is also increasing. The number of EK has doubled from 60 to almost 120 at the end of the study period. Similarly, a 3-time increase in the number of penetrating keratoplasty for the same indication. If you see Western published literature, an interesting study from Saudi Arabia, where in the first 5-year period of their study, scar was the most common indication for doing a keratoplasty. However, in the next 5-year period of their study, keratoconus became the most leading and common indication. If you see other studies from Israel, from US, from Singapore, the indications vary from keratoconus, bullous keratopathy, scar. Again, Fuchs is most common in the United States. If you see the huge study by Park, a 10-year review, again, pseudophakic bullous keratopathy is the most common indication. But the scenario is somewhat different in our country. Old study from L.V. Prasad in 1997, where scar was the most common indication for doing a PK, lamellar was not available at that time. Then from RP Center, again, scar was the most common indication. Then scar after healed corneal ulcer, again, 60% of the cases from southern India. Again, one study from L.V. Prasad where looked at only endothelial keratoplasty, where pseudophakic corneal edema was the most common indication, almost 50% of their caseload. And then coming to this study where active infectious keratitis accounted for almost 41% of the cases, followed by bullous keratopathy at 22% and corneal scar after healed corneal ulcer or any other trauma at almost 18%. So in conclusion, active infectious keratitis is still the leading indication for performing a keratoplasty in this part of the country. Penetrating keratoplasty is still the most common type, but lamellar is showing a rising trend, and failed graft is becoming an important indication for endothelial keratoplasty. It always gives us much pleasure to see outcomes like this. Thank you.
How will you explain this shift from scars becoming changing from the most common indication to infectious keratitis being the most common indication for keratoplasty in your area?
At least where our center is concerned, a couple of reasons. The number of tissues collected through the HCRP program has gone up dramatically in the past 5 years. Then we are intervening at a bit earlier stage.
Why?
Sir, because
is medical management not working in cases of infectious
No,
keratitis?
sir. Up to 2/3, the ulcer depth extending beyond 2/3 of the stroma, it is not responding to intrastromal or intracameral injections of amphobi and or borizol. And many a randomized control trial from AIMS has also shown that beyond a certain limit, it doesn't work as well as it should. And there is a general reluctance amongst the other population, the ophthalmologist population, to intervene in cases of active infection, since the perceived outcomes are very poor. So cases end up getting referred to our center. By the time they reach, if it's a bacterial ulcer, it is mostly taken care of by the general practitioners. But deep advanced fungal keratitis, we are left with no other choice but to surgically excised.
So it could be because of more referrals of
There is a
complicated cases
definite
in your
referral bias,
area.
and since we are having good quality tissue, we are using optical grade tissue in this therapeutic group also, so that we can have a better outcome.
Okay.
Only one observation that I would like to make, that whenever we think of therapeutic keratoplasty or keratoplasty in conditions like infectious keratitis, we earlier days also we used to use a lot of cornea, those were discarded, grade 4, grade 3 corneas. Even sometimes glycerin preserved cornea also we use because of paucity of the donor material. But because of the availability of the donor material, particularly in the tertiary centers, the keratoplasty in infective condition using a good donor material, results are definitely has become improved. And I also feel in one way that if you put a good cornea in an adverse situation, chances of taking up of that graft towards the optical side is much more as compared to putting a compromised tissue into infective condition.
Okay, thanks. Now I would like to request Dr. Alok Sati to present his paper on corneal endothelial changes in CRF patients, relevance to cataract surgeons.
Yeah, good afternoon, good morning, ladies and gentlemen. At the outset, I would like to thank the organizing committee to make me deliver this topic, which is hardly touched but of great significance to the cataract surgeon. We know that in chronic kidney disease, there is a decline in glomerular filtration rate, and there are 5 stages in it, where the stages 3 to 5 come under the purview of chronic renal failure. Stages 3 and 4 come under non-dialyzed state, whereas the patients who undergo dialysis come under stage 5. There are n number of ocular changes in CRF which has been described in literature. Now, what could be the factors for it? It is attributed to breakdown of homeostasis of aqueous humor. As a result, many undesirable substances like urea get accumulated, and it is presumed that these unwanted agents may cause endothelial alteration, and it is what we are trying to prove in this study. So a total of 128 corneas of 128 subjects have been included, out of which 32 in dialyzed group, 34 non-dialyzed group, and 64 age-matched control group. This group calculation has been measured from this very complicated formula as you are seeing on the slide. All the corneas were subjected to specular microscopy, and the endothelial parameters that were analyzed included CCT, coefficient of variation, percentage hexagonality, and cell density. In addition to that, the dialyzed group has also been analyzed to assess the influence of various toxins onto the endothelium, including the duration of dialysis. Conditions which affect both ocular and systemic, which affect corneal endothelium, have been excluded from the study. So if we look into age using ANOVA, an insignificant difference was seen amongst the 3 groups. Again, using ANOVA, we found that a significant difference was seen only in central corneal thickness and in cell density. And that's what it is. And using Tukey test, when pairwise comparison was done, both in CCT group and in CD group, we found that the significant difference was seen between the dialyzed and control group, between non-dialyzed and control group, and also between dialyzed and non-dialyzed group. When we looked for the influence of blood toxins using linear regression model, it's only in urea we found that there was a significant difference within the endothelial parameters. And this significant difference was positive in terms of CCT, whereas a negative but significant correlation was seen in terms of CV, CD, and percentage hexagonality. Also, when we looked for the influence of duration, we found that as the duration increases, there is insignificant difference in terms of various endothelial parameters. When we looked into the literature, we found that there is a scant literature related to this topic. We could just find the two reports, one published in American Journal way back in 1999 and another in Cornea in 2007. So what could be the possible attributors for this? One, it could be accumulation of multiple toxins in blood, which in turn are raised in aqueous humor, and that may affect the endothelium. Second, we all know that CRF is a state of oxidative stress. So obviously there is reduction in reduced glutathione in aqueous humor, and we all know that reduced glutathione is important for functioning of endothelium. The third, we all know that CRF is a state of hypercalcemia. So it could be the needle-like crystals may deposit in the endothelium and they may disrupt these endothelium. And fourth, why there is more damage in dialysis session, it may be because of phasic or episodic increase in nitrogen level in tear film along with decrease in tear secretion during the dialysis session. So what is great about this study? The greatness lies in its difficulty to perform, especially in an ophthalmic setup where it is very difficult to get so many number of patients. Not only that, this is the first study which has taken such a large number of patients and has compared the three groups. In addition to this study also makes us aware that we have to be extra careful while doing intraocular procedures like phacoemulsification in CRF patient, which we often think other way around. All studies have certain limitations, so this study does have, because we have not been able to analyze the different stages of CKD, that's one. And secondly, what we feel that it would be more authentic if we estimate the aqueous urea level and to assess its influence on the corneal endothelium. Thank you for your patience.
Just one comment. So you told the thickness in the dialysis patient was higher in comparison to the non-dialyzing patient.
Correct.
Is it attributable to the endothelial function?
Yeah.
Do you think because of the poor endothelial function, the thickness is more in a dialysis patient?
No, not because of that. I have mentioned that it is the episodic decrease in the tear meniscus height and episodic decrease in the tear film,
Okay.
which might have an hypoxic effect onto the corneal endothelium. And because the difference was seen only during the session.
Okay.
That was it.
Thank you.
Thank you. So the next will be is the best paper from Chhattisgarh Ophthalmic Society, and the presenter is Dr. Samrat Chatterjee. So he will be presenting Acanthamoeba keratitis, clinical features and treatment outcome.
If time permits, later on we can take.
Non-ratified members are not supposed to get any award, number one. Number two,
If time permits,
if time permits, we'll allow you to present.
Good morning, members of the dais and my colleagues. I'll be presenting on Acanthamoeba keratitis. It's a challenge to treat Acanthamoeba keratitis not only because making a diagnosis is difficult, but also because the treatment, the drugs that are used for this treatment, they are not commercially available. So we wanted to see the clinical characteristic and diagnosis and treatment outcome in our patients. We're trying to find out what are the typical and atypical features, and the secondary objectives being the treatment duration and outcome. So this was a retrospective case series that we did over a 10-year period, and we diagnosed Acanthamoeba cyst based on the appearance of a double-wall cyst, either in KOH or in gram stain. So you can see the double-wall cyst out here. And we reviewed the demography, medical history, clinical characteristic, and treatment of all these patients who were positive on smears. And we tried to classify the ulcers as typical or the other types and compared different parameters with this clinical differentiation. So we had 12 patients, a majority being male with an age group of around 38.75 years. and most of them were in the rural areas as expected and mostly engaged in agriculture. And 9 patients reported a history of ocular trauma, a minor ocular trauma, and 7 patients reported history of exposure to dirty water, that is either pond water or, in certain cases sea water or rose water, or, water from the irrigation ditches that are present near the field. And if you look at the clinical presentation, we could differentiate it into 3 different types. One is the typical ring ulcer that we have always been classically taught about it. The second is a fungal stromal infiltrate, which has an appearance like a fungal ulcer. And the third is epithelial lesions, which have a very varied and atypical presentation, mimicking the viral keratitis picture. And if you look at the mean time between the onset of symptoms and presentation, we see that the atypical patients with epithelial lesions presented much earlier than the typical ring ulcers. And if you look at the diagnosis, we could diagnose Acanthamoeba keratitis in 7 patients on the first day, that is at presentation. And in 5 patients, you could not diagnose it at presentation. And if we again see in the different types, there was a delay in diagnosis in patients who had atypical features that mimic that of viral compared to the typical ring ulcers. And the reason for the delay in diagnosis was that in 2 patients, we could not identify the cyst on the initial scraping, and they were identified later on. And in 3 patients, because of these epithelial lesions, we did not scrape them, and only when the cases worsened and there was stromal infiltration, we scraped and we could diagnose the case. Treatment on the first day, 7 patients were treated with neosporin, and only 4 patients were treated with amoebicidals like polyhexamethyl biguanide and chlorhexidine, that is PHMP and CHG. And this was because only in 2 patients did we had the drug at presentation. 7 patients received the correct amoebicidal drugs within the 1 week, and around 5 patients had a delay of more than a week before they could be treated with the correct drug. If you look at the mean duration of treatment, it is always prolonged in Acanthamoeba keratitis. It is nearly around a month, and the atypical features in this had a slightly earlier clinical resolution. If you look at the outcome, 9 patients had a good outcome, and 3 patients had a poor outcome. 1 patient required evisceration because this patient had progressed to sclerokeratitis, which we could not salvage. If you look in literature, in Western countries, contact lens wear is the most common risk factor with epithelial lesions mimicking viral keratitis, while in a tropical Indian scenario, it is mostly trauma with exposure to dirty water and a stromal infiltrate that is more common. If you look at the treatment duration, it is always prolonged with people requiring at least 2 to 3 months of treatment. However, our outcome was similar to outcome that has been reported from other studies. The limiting factor in treatment of Acanthamoeba keratitis is that atypical features will often not make us think about Acanthamoeba keratitis. So we need to be have a strong clinical suspicion, especially when the lesions are atypical, epithelial, not responding to topical antivirals, and microbiological workup. Our microbiologist should be oriented about this cyst, and if possible have culture techniques. The drug availability, unfortunately, is beyond us, and it's very difficult to get these amoebicidal drugs, and we need to keep in mind that the treatment is prolonged, so we have to persist with the treatment for a long time. Thank you.
Just one comment, sir. Was there any secondary infections associated with Acanthamoeba keratitis in your cases, like any other bacterial?
No. In this case of 12 cases, we did not get any secondary bacterial or secondary fungal infection, but they can coexist. Okay. And then again, the diagnosis becomes difficult because you'll pick up the fungus earlier and the Acanthamoeba later. The only problem is that we don't have culture. The culturing is very difficult. So all labs, all ocular micro labs cannot actually sustain a culture thing. And
just the thing, the case which you told about the progression to the scleral involvement, I was just suspecting whether there was any other organism which is in. No. So it was the.
It was a single case which I presented in 2005 December, which we treated, and we have published that also. But there, that case progressed to scleral infection, and when we did biopsy of the sclera, we didn't find any live Acanthamoeba it has been reported that you can get in sclera live acanthamoeba, but what we got was a granulomatous inflammation. So the acanthamoeba must have been there, which the topical amoebicidal drugs could have killed it, and then the antigens could have prolonged that reaction. And sometimes it's very difficult to pick up these scleritis because the treatment with
made our parameters fixed. We put in the incision size being at the steepest meridian. So all this data has been fed into the femtosecond laser, though it is also possible using a manual dissector. But ever since the advent of the femto laser, this is how we perform the intact segments. Now this is the most crucial step, as you can see, going in vertically, opening the incision, and then turning it by 90 degrees to open the pocket. And again, on the other side, you go in first vertically, lying exactly perpendicular to the cornea, and then turning in horizontally. And then you gradually pick up the ring segment. And I think I'm going to have to skip this video a little bit. So you introduce the segment very gradually, and then on the other side. And at the end of the procedure, you make sure that the segment is lying at least 1.5 millimeters away from the incision. And then you close the incision with knots to prevent further migration of the segment, and followed by a scraping of the epithelium, and to be followed by a C3R procedure. So this is a look at our results. This is a patient we followed up for more than 2 years, and if you look at her UCVA and her BCVA, you can see for yourself how much of an improvement there is. Of course, this is one of our better examples, and again, her improvement in her refraction is evident with the dropping to 0.75. Yet another example where the astigmatism dropped by nearly half, and this is another patient with a very severe keratoconus. If you look at her Kmax, it's about 78, which dropped to about 62 after 2 years of follow-up. So we look at our results with the simultaneous procedure. We've done about 250 eyes, and the Kmax dropped by 3.4 diopters. And we look at the vision gain, we find that about 90% patients will have an improvement of 1 line or more, and about 50% will have 2 lines or more. So yes, you cannot make them perfect, but there is a significant improvement that you can offer to your keratoconus and ectasia patients. And you get a rapid and predictable improvement when you combine the two results. Of course, a good case selection, planning, and counseling is needed. And if you can identify and manage your complications well in time, then this single-sitting procedure gives you both a disease control as well as a visual improvement. Thank you.
Just one question, madam. The vascularization in the cornea, you told,
Yes.
whether it was a coexisting morbidity of allergic conjunctivitis?
Yes, because a lot of these patients are contact lens users prior to the procedure, and they all usually have a superior vascularization, and these puts them at a higher risk for getting this procedure. So you have to tell them not to rub their eyes, especially after an intact procedure. But we've had, I've had to remove about 5 segments because of vascularization. The good thing is, because the cornea has already become rigid, they don't really lose their visual acuity. Even after you've explanted, the cornea maintains its rigid shape. So that's the advantage.
Anybody has any questions for her? Because she is not in the competitive section, so you can ask one question from her. Anybody, any observation?
We've started doing it now, but we use the 9-minute protocol. But I think majority of our patients were also, because they've shown a greater follow-ups, and accelerated has just started in the last 1 month. So I would say for about 70% of my results are done with a regular procedure. For the last 1.5 years, we've been doing the accelerated protocol. They're doing pretty well so far. Like I said, I have a better follow-up of the older patients for about 5 to 6 years. But in the last 6 months, like I said, about a year or so, they're doing almost as well as the patients. There's no difference in the result, no significant difference. Yes, they say that actually gives you a more flattening in the area of the segment, so that is being followed by some people. We have so far not done it because there was another study which did say that there was some amount of increased white cell reaction happening when you did that. And so we've kind of still saying safer, but yes, I know there are people who are putting it in the channel itself, yes. Thank you.
Okay, thank you, Dr. Charu. Now I would like to invite Dr. Bhushan Godke for the next paper.
Good morning, everyone. The topic for today's presentation is pattern of anterior corneal and posterior corneal astigmatism in keratoconus. The peculiar feature of posterior cornea is it behaves as a minus lens because it is stiffer vertically in majority of the patients, creating a net par horizontally, which is termed as the against rule astigmatism on the posterior corneal surface. So this puts us into 2 categories where majority of the patients where there is with the rule astigmatism anteriorly and against rule astigmatism posteriorly, we get a net neutralization of the corneal par, and therefore there is less total corneal astigmatism. And in the second category, if there is an against rule astigmatism, there is accentuation of the corneal astigmatism because of the against rule astigmatism on the posterior surface, therefore creating more corneal astigmatism. Keratoconus, as we all know, is a progressive non-inflammatory thinning disorder, and as studies are published that the first sign of keratoconus is apparent on the posterior corneal surface. Here in India, we being an equatorial country, so we have, because of the influence of the environmental and ethnicity, there are more chances of keratoconus in our country, leading to a relatively higher incidence. So, whenever keratoconus patients are managed with toric IOLs or rigid gas permeables lenses, we get refractive surprises. This is akin to the posterior corneal astigmatism. To our knowledge, this is the only study which tries to find the pattern of astigmatism in keratoconus in India to find down the treatment in keratoconus. So we assess the magnitude and axis orientation of anterior corneal astigmatism and posterior corneal astigmatism in keratoconus. It was a retrospective study in Sadguru Nitra Chikitsalaya, Chitrakoot, where medical records of 42 patients were reviewed between 2015 and 2016. Keratoconus was termed based on the corneal topography and clinical classical science of keratoconus. We excluded patients with other critic conditions, corneal disease and scarring, and previous surgeries. Recent history of gas permeable lenses or whatever, if any contact lenses were worn, the patients were asked to discontinue before the corneal imaging. Pentacam was used, which is a Schemflech, which based on the Schemflech principle for all the corneal imaging in all the patients, and quality specification OK were only included in the study. 3 parameters were included for the patients, that is the anterior posterior corneal astigmatism and its characteristics, its magnitude, and its astigmatism axis. We define anterior corneal astigmatism where the steepest meridian on the corneal surface lied between 60 to 100 degrees, which was termed with the rule, while against the rule was where the steepest meridian was between 0 to 30 or 150 to 180. In contrast, posterior corneal astigmatism, because it acts as a minus lens, with the rule astigmatism was whenever the steepest meridian was between 0 to 30 or 150 to 180, and against the rule was the opposite of it, and the remaining values were termed as oblique. Data analysis was performed by IBM's statistic, the version 22. Nominative data was assessed by Kolmogorov mono test, and chi-square test was used for analyze categorical variables. In our study, males outnumbered females. Majority of the patients lied in the age group of 60 to 20 years, followed by 21 to 25 years with a mean age of 21 years. The manifest spherical equivalent was 5.14 diopters with a manifest cylinder of 2 diopters, and the mean keratometry was 55 diopters. In most of the patients, we had with the rule astigmatism on the anterior corneal surface, which was again neutralized with the posterior corneal astigmatism, where the dominant pattern was against rule astigmatism. There was a significant correlation between the magnitudes of anterior and posterior corneal astigmatism. In the past, topographical analysis of anterior corneal surface has traditionally been the principal tool for characterizing keratoconus. The posterior corneal surface previously was calculated based on the values of the anterior corneal surface, but with the Schemflech imaging, we now can document the characteristics of the posterior corneal surface in a better situation. Therefore, in eyes with increasing amount of with the rule astigmatism, there is a corresponding increase in the posterior corneal astigmatism, which may go to a value of about 1 diopter, which is clinically significant. So, it is very important to evaluate the posterior corneal surface in such patients. Our results demonstrated that the mean magnitude of anterior and posterior corneal astigmatism were approximately 5 diopters and 1 diopter respectively. 75 to 90% showed with the rule astigmatism and against rule astigmatism on the posterior corneal surface. One similar study, we have a similar values in comparison with the similar study with 65 eyes of keratoconus patients. Also, Shen and Yoon have reported that there is a larger amount of higher order abrasion, which is because of the intraocular astigmatism, which has now been proven to be posterior corneal astigmatism. Thus, keratoconus patients, whenever they are managed, they give a very erratic astigmatism in the post-management phase. Against the rule astigmatism on the posterior corneal surface compensates for with the rule astigmatism, and therefore the astigmatism is reduced. But in cases it may be accentuated, and therefore this factor should be kept in mind. The limitation of study was it was a retrospective study and no comparison with the normal population. So we concluded that mean magnitude of the anterior astigmatism were 5 and 1 diopters, which is clinically significant. Dominant astigmatism pattern on the anterior was with the rule, and it was against the rule in the posterior corneal astigmatism, and it may result in a more accurate correction and can fine tune the treatment of keratoconus patients. Thank you.
Okay, thanks.
Thank you,
Dr. Bhushan. Now, I would like to invite Dr. Lionel Raj D from Tirunelveli. present the paper on pre-decimates endothelial keratoplasty, our unit till date.
There are 3 papers, we'll be taking those after the award papers, okay? Those papers, those presenters are not ratified members, so they will be allowed to present. Okay, there are 3 papers altogether in this session.
Respected chairpersons and good morning everyone. So today I am going to talk about why do I prefer pre-decimates endothelial keratoplasty over conventional procedures. I have no financial interest. So it is Dr. Harminder Dua who explained even when there is a decimates membrane which is stripped out, using a pneumatic dissection he found a tough resistance offered by pre-decimates layer, and he demonstrated it by various microscopy, and he called it as pre-decimates layer. It is Dr. Amar who used it into clinical scenario. This is one of my case, Fuchs dystrophy case and with cataract. So what I did is I introduced air-filled syringe with 26 gauge needle right into the center and did a pneumatic dissection of pre-decimates layer, stained it, marked with a 7.5 to 8 millimeter trephine and fashioned a pre-decimates graft. And subsequently the graft is stored in the storage medium. Then I went into the case, did a coaxial microphacoemulsification and loaded the graft into a Medicel MI60 injector, stripped off the diseased decimates membrane complex, injected the graft. This was the technique which was taught by Frank Price. Removed the epithelium for visualization, as well used an endo-eliminator, unrolled the graft and attached by means of air bubble. And this is how the graft, in fact it was from a young donor, was on day 1 and at 3 months. This is one of other case where I had a graft failed graft for which a same procedure was done. Did a phacoemulsification, removed the deceased decimates membrane complex, created a pre-decimates endothelial graft, use of endo-eliminator to visualize, and I bubbled it. This was another case which was an iatrogenic decimatorexis made by one of our surgeons substituting a capsulorexis. The overhanging decimates is seen, a real capsulorexis was performed then, a phacoemulsification was done, and a graft was attached with the air bubble. So most of our indications were pseudophakic bullous keratopathies and endothelial dysfunctions following dystrophies. We also had cases of iridocorneal endothelial syndrome, PXF syndrome, associated with endothelial dysfunction. We also did PDEC in a post-hydrops case. Also we had 2 cases of post-trap glaucoma with endothelial dysfunction. So coming to the donor age, most of our donors were less than 40 years of age, where a DMEC graft could not be done because of adhesions of or adherent decimates endothelium to the underlying structure. It clearly states pneumatic separation is superior to mechanical dissection in younger donor corneas. We also compared the central corneal thickness with DMEC. The assumed 517 of Theophilus and 520 microns of central corneal thickness of Price group, ours was 565, which was closer to normal, whereas when we considered DSEC group, it was 618 and ours was closer to normal. We also had a significant improvement in visual acuity from 1.41 logMAR unit to 0.35 logMAR unit. We had only 3 cases of graft failure, which ranged outside, and 2 required rebubbling. We also analyzed the endothelial cell loss by 6 months, and this was the comparison. We had 23% of endothelial cell loss at 6 months, whereas DMEC is 40% and DSEC is 38% by Theophilus. Again stating a pneumatic separation is superior to mechanical dissection in preparation of the tissue. We also compared it with Ham et al. who showed 24% cell loss by 6 months, and price group 30% at 6 months and 37% by 1 year, again stating pneumatic separation is superior to mechanical dissection. We compared it with PDEC, between PDEC and conventional PK. PDEC is a procedure which is pain-free. It's a day care procedure, back to routine activities in within a week, and there is no suture emergent adverse reaction. So, pre-Decimet's endothelial graft preparation is easily reproducible. Any donor age could be employed, especially younger donors, and normal corneal thickness, no suture-related adverse events, and better in endothelial preservation. So earlier in my practice, it was a manual DSEC, and in middle of my practice, it was DMEC, and present preferred endothelial keratoplasty of my choice is pre-Decimet's endothelial keratoplasty, and of course, endoeliminator is an essential part of my surgery. Thank you, sir.
Sir, only one question, sir. In the initial stage when you learned this PDEC method, what was your rebubbling percentage? Is there any rebubbling percentage in this case?
Yes, I had 3 cases. Out of 48 cases which I mentioned here, I had 3 rebubbling.
Okay. So it is significantly less in comparison to your DMEC learning curve?
I didn't hope so, sir. I didn't have a significant difference between both of them.
Okay, so in DMEC also the same number you had?
Correct. It's almost the same. It's almost the same. To be precise, it is we have 20 or 30 microns more of tissue, the pre-Decimet's tissue. So the unrolling should be even more better than DMEC graft. But to my knowledge, it is, to my practical thought, it is almost the same.
And how do you differentiate stromal side from endothelial side?
The stromal side always curls.
It's just similar to DMEC? Or?
Correct. You are right.
You did not use any marking on stromal side?
I didn't use, sir. None of the cases I used. But of course, I believe marking can help us.
Yeah, it will help correct to limitation. Okay, now.
Thank you so much.
And now we would like to invite Dr. Neha Shilpi to present the paper on analytics of subbasal nerve plexus in healthy and diseased cornea.
Good morning all. I'll be presenting on analytics of subbasal nerve plexus in healthy and diseased cornea. I have no financial disclosures to make. So why do we need to study corneal nerves? In our clinics, we often see patients who complain of discomfort after cataract surgery, burning, grittiness and dry eyes. And when we do the routine dry eye evaluation, they come out to be normal. The signs do not correlate with the symptoms, and we often wonder what is the missing link. So our research question was, what is the implication of corneal nerves in ocular discomfort and quality of life? And can nerves be early predictor of ectatic corneal disorders? So we conducted a study with the purpose to analyze the changes in corneal subbasal nerve plexus on confocal microscopy in healthy and diseased cornea. Our study had 2 arms. In the first, we studied patients with dry eye, and in the second arm, we studied patients with ectatic corneal disorders. So in the first arm, we had 47 patients of mild evaporative dry eye and 66 control eyes, which we included in group 1 and group 2 respectively. We did Schirmer's 1, tear breakup time, ocular surface disease index scoring, confocal microscopy, and collected tears for all. Ocular surface disease index score is a validated questionnaire which has questions pertaining to the symptoms of discomfort and vision. So how do we study the nerves? This is the image of a confocal microscope where the nerves can be seen as hyperreflective areas. This is analyzed with the help of CC metric software. So in the analyzed image, we can see the main nerve fiber denoted by red, the blue denotes the nerve branches, and the green color denotes the branch points. There are few examples of how the nerves look in normal and diseased cornea. So the left side picture shows a healthy cornea, and in the right side we see that there is reduced nerve fiber density and reduced branch density in a case of dry eye. This is how the nerves look in case of inflammation, where we can see many dendritic cells. So coming to the results, what we found was the patients who had an ocular surface disease index score of more than 23 had significantly reduced subbasal nerve plexus parameters. So we concluded that high OSTI correlated with reduced subbasal nerve plexus density. Similarly, we found that higher the dendritic cells, more was the ocular surface disease index score, and this specifically the dendritic cell number correlated with the OSTI discomfort subscale. So we concluded that OSTI scoring should be incorporated in dry eye evaluation, especially in patients with disproportionate high pain, and confocal microscopy changes in subbasal nerve plexus provide valuable information and correlates with OSTI scoring. Coming to our second arm, we had 30 normal subjects which we included in group 3 and 33 patients of unilateral keratoconus whose normal eye we included in group 4 and the affected eye in group 5. We did ocular examination, confocal microscopy and pentacam for all. So this is what we found. In the normal individuals, there was normal density of nerves and no tortuosity. In the fellow eye of unilateral keratoconus patients, there was decreased nerve density with mild tortuosity, and in the affected eye, there was very low density and severe tortuosity of nerves. So this is the table showing the results. In the normal individuals and in the affected eye of unilateral keratoconus patients, there was significant difference in the nerve parameters. The parameters were reduced in patients with keratoconus. And when the normal individuals were compared with the unaffected eye of unilateral keratoconus, there was again a difference in few of the nerve parameters. This shows the difference in nerves in case of post-LASIK. So the left side picture shows a case of post-LASIK without ectasia, where we see normal nerve regeneration, while the right hand side shows the picture of post-LASIK with ectasia, which shows reduced nerve regeneration and increased number of dendritic cells. So coming to the translational potential of this, when we link tear biomarkers to the confocal microscopy, it definitely helps us to understand the disease better. So what we found was that there was increase in the pro-nociceptive factors and decreased anti-nociceptive factors, which could explain the high OSTI. There were increase in the inflammatory markers, and also there was an increase in few anti-inflammatory markers as a compensatory mechanism. There was increased goblet cell loss, which could explain the dry eye. So our second arm, we conclude that alteration in corneal nerve morphology may be used as an imaging marker for early diagnosis, monitoring and prognostication of keratoconus, and confocal microscopy can serve as an imaging tool to provide insight into the pathogenesis and influence the management strategy of these patients. Our limitations, however, that we studied only the central cornea and the instrument is costly. So in dry eye, we already know that disproportionate pain is because of the nerves, and subbasal nerve plexus density is altered in dry eye patients. Our study adds that high OSTI correlates with reduced subbasal nerve plexus parameters, and thus it has a role to play in symptomatic dry eye. In keratoconus, we know that the subbasal plexus of nerves shows a reduced nerve fiber density and increased tortuosity. Our study adds that these changes occur early in the disease and therefore help in establishing the diagnosis of keratoconus even before it is manifested clinically or topographically, and these changes also help in monitoring disease progression. Thank you.
Dr. Jatin, please call 4, 7 and 8 papers. Thank you.
Thank you.
Good morning, everyone. My name is Radhika Dashputra. I am second year resident at Guru Nanak Eye Center, Delhi. And my topic for today's presentation is corneal epithelial thickness mapping in keratoconus using Fourier domain optical coherence tomography. As we all are aware, keratoconus is a progressive disorder characterized by central or paracentral corneal stromal thinning, ectasia and apical protrusion. Diagnosis of keratoconus has traditionally been based on slit lamp examination and topographic features. However, these techniques can only diagnose manifest cases. What has been up and coming in diagnosis is epithelial thickness mapping. Various studies have agreed that some level of epithelial compensation occurs in keratoconus to mask underlying stromal irregularity, and it has been shown that corneal epithelial integrity is vital in maintaining the optical clarity. In 2010, Reinstein et al. Published a study using very high frequency ultrasound in which they demonstrated localized central zone of thinning surrounded by an annulus of thick epithelium, which they labeled as an epithelial donut pattern. Yanli et al. Have conducted multiple studies in OCT-guided epithelial thickness mapping and have established that epithelial asymmetry and thinning in the area of cone could be an early marker for diagnosis. In 2015, Temstead et al. Gave a cutoff value of 52 micron for distinguishing form thrust cases. However, Sandali et al. In 2013 published a study in ophthalmology in which they demonstrated epithelial thickening in the area of cone. This variability in the nature of epithelial compensation, lack of studies in the Indian population and in younger age group led us to conduct a study in which we determined corneal epithelial thickness in normal and keratoconus subject and correlated it with various grades of keratoconus. It was a prospective cross-sectional study in the conducted in the age group of 7 to 30
acyclovir and steroids was 52 days. So these results, they are very small numbers, just 3 cases and 25 cases of negative to be compared. But what I would like to highlight is of the 3 cases of corneal ulcer, one had a of HSV keratitis, one had a good improvement of 6/9 vision. One had a moderate, only low vision, which was 6/24, and the third person was only hand movements. That was because of a corneal scar. It was only 33% in the HSV positive group, but 64% of the culture negatives actually had economic and social blindness. So my discussion would be that even though we know there is actually no report on what the etiology of contribution of virus is in culture negative corneal ulcers, and certain risk factors like past history of red eye and corneal ulcers should raise the suspicion of a HSV positivity. And if we have such factors, it is advisable to send a sample for HSV PCR at an early stage instead of waiting and continue the treatment of empirical antibiotics. Thank you.
Only one comment. Did you check any immunocompromised status in these patients routinely?
No, sir, we don't do that as a regular.
Okay.
Now I call upon next presenter, Dr. Rohan Agashi.
Good morning. I'm Dr. Rohan, and I'm going to be speaking about microsporidial keratoconjunctivitis, increasing incidence and ocular morbidity in South India. Microsporidia are a diverse group of obligate spore-forming intracellular eukaryotes which are closely related to fungi. They can be easily stained by Gram stain, modified Zeal-Nielsen stain, or chalcofluor white with potassium hydroxide, which has the best sensitivity according to a study by Dr. Jovita Joseph et al. They cause keratoconjunctivitis and stromal keratitis in the cornea. Awareness of this disease is increasing over the last decade. It was initially thought to be a disease of the immunocompromised, but increasingly it is seen in healthy individuals. It was initially believed that stromal keratitis is seen in immunocompetent, whereas keratoconjunctivitis is seen in immunocompromised individuals. But nowadays, most of the cases which we see are keratoconjunctivitis in healthy, normal individuals. The prevalence of this disease is anywhere between 0.4 to 19.7% of all cases of microbial keratitis, according to a paper by Joseph J. et al. This is often misdiagnosed as adenoviral keratoconjunctivitis. The characteristic appearance of the disease is like multiple coarse raised epithelial lesions with mild to moderate conjunctival congestion, so-called coarse SPKs, which can be easily scraped off with a cotton bud also, which are morphologically different from the fine SPKs which are generally seen in adenoviral keratoconjunctivitis. The aim of our study was to analyze the demographic profile, treatment outcome, and ocular morbidity in these cases. It was a retrospective study of 550 patients who presented with microbiologically proven microsporidial keratoconjunctivitis in our institute over a period of 3 years from January 2013 to December 2015. We assessed the demographic data, predisposing factors, clinical course, treatment, and visual outcomes in these patients. Now, what we studied was 577 eyes of 550 patients. We saw bilateral involvement in only 5% of patients. The mean age of our patients was around 36 years with a range of 6 to 85 with a slight male preponderance. The mean time to presentation was around 6.5 days. What we saw was a 2.4-fold rise in the incidence in our 3-year study period compared to the previous 3 years data. Now, this graph shows a monthly distribution of smear proven microsporidial keratoconjunctivitis. What you can easily see is that the prevalence or the number of cases increases significantly in the second half of the year compared to the first half, which is statistically significant, with a peak in the month of November. Now, October to December is around the monsoon season in Madurai and around. But then we also see that the incidence increases dramatically from July onwards. So, no particular seasonal correspondence. Now, coming to the risk factors, around 80% of our patients did not recollect any history of either exposure to dust or contaminated water or any other risk factor. Now, the patients who came to us, around 52% were previously treated, out of which 52% had been treated with antibiotics, and around 13% had been previously on steroids, whereas 13% had been receiving antivirals. Now coming to the time to resolution among our patients, around 72% of our patients resolved in within 3 weeks. Now this was a visual acuity comparison from baseline at till 3 weeks follow-up. Because the mean time or mean follow-up period of our patients was around 3 weeks. The improvement in visual acuity was seen in around 15% of patients from baseline. No significant change was seen in around 80%, whereas worsening was seen in 4% of our patients. That is plus or minus more than plus or minus 1 line from the baseline. Now, our study, to our best of our knowledge, is the single largest study on microsporidal keratoconjunctivitis till date. What we saw that there is no need for a specific exposure to risk factors for causing microsporidal keratoconjunctivitis. There is no significant seasonal association, and patients come with frequently prescribed drugs, being antivirals, and steroids. Previously used treatments have been polyhexamethylene biguanide, itraconazole, systemic albendazole, fumagillin, but no paper has given a clear-cut data. Most treatments remain controversial. Corneal epithelial debridement has been tried, but by a study by Das et al. Shows that there is no significant advantage. Recent study by Fan et al. Shows that repeated corneal swabbing over a period of 1 week is effective. In our institute, we use 0.3% topical fluconazole eye drops, that is Zocon, 6 times a day, with or without 0.3% topical ciprofloxacin eye ointment twice a day. To conclude, microsporidal keratoconjunctivitis is quite common in South India. It can be easily diagnosed by gram staining. The visual outcomes after treatment are generally good. Topical fluconazole is effective in treatment, and a significant proportion of patients require treatment even after 3 weeks, which has economic ramifications. Thank you.
Just any cases were taken for keratoplasty in these cases?
No, sir.
Do you have any?
No, sir. Keratoconjunctivitis generally
it is
not
healing, but because Sujata Das, which has published, she took some. She did keratoplasty.
So that was stromal keratitis.
Yeah, stromal.
Yeah.
So any cases like that you have experienced in your?
Not in my period here, sir. But one case we had of stromal keratitis, which went for keratoplasty. But sir, this is only keratoconjunctivitis which we took in our study, sir.
Why are you advocating fluconazole? These cases, they spontaneously resolve in 2 to 3 weeks. And even if you mechanical debride and just give a broad spectrum antibiotic or lubricants, they are treated on its own.
Yes, sir. Sir, what we saw in our institute that these patients have already been on antibiotics, especially the fluoroquinolone group of antibiotics, or have been receiving antivirals for at least 1 week or 2 weeks, where they are not resolved. And when we started fluconazole, after 2 to 3 weeks, most of patients who resolved had quite clear corneas without any residual cervical scar.
Have you tried mechanical debridement?
No, sir, not debridement, but diagnostic debridement was done to diagnose these cases,
Yes,
but not
if
in
you
a
do diagnostic debridement, then it treats on its own.
Yes, sir, it's what they say, but sir, in our institute, we are not seeing them getting results.
So there is no point in adding antifungal to the treatment. You can just treat them with simple debridement and antibiotics and lubricants.
Okay.
Yeah, any fluoroquinolones, broad spectrum you can give.
Any questions for him? No? So now we are coming to the last part of our job, and I must thank Dr. Jatin, Dr. Praveen, and Dr. Pratik. And actually we are just evaluating all your pre-papers, and most of the papers are really very good to very high standards, but somebody has to come first and second. So considering all these points as given to us, like content of the paper, presentation of the paper, slides and originality. So we have concluded that we have actually marked all the papers, but we have taken up marked 3 marks 1, 2 and 3. The third paper, I am coming from the third to first. Third one is by Dr. Leonal Raj on, sorry, that is second. Second paper is Dr. Leonal Raj, so this one is third. Third paper is by Dr. Samrat Chatterjee, that is Acanthamoeba keratitis paper. second paper is by Dr. Leonard Raj, as I already said. That paper was pre-descimate endothelial keratoplasty. And the first paper, which has got the actually some originality, that's why we thought this is the best paper in this session. That is by Dr. Natasha Pahuja. It's a really good paper. So thank you. But this paper, whatever I have announced or we have announced here, this is on this hall. Rest of the thing will be announced at the scientific committee chairman's office. Thank you. Yes, Pratik. Thank you. Thank you, sir. Thank you. वो भी रखना है इंडिविजुअल मार्किंग तो कैसे करेंगे पेपर ले लिया आपने डेली कैसा रखेंगे इसको ऐसा करके रख सकते हैं सबसे ऊपर इसको रखेंगे सिग्नेचर सब इसमें मास्टर चार्ट करके मैंने रखा है ऐसा करके फोल्ड कर देता है ठीक है मास्टर चार्ट करके दिखाइए सील करना कैसे